Well, hey everybody, it's Sandy and welcome back to my channel dedicated to helping you advocate for your own health, one topic at a time. So guys, today I'm going to continue our discussion on thyroid replacement, and in particularly I want to talk about how do you know if you need T3? So let me just insert my usual disclaimer here before I even get started, which is that nothing that I say on this channel should be deemed medical advice that is a substitute for that of your own practitioner. I'm not giving any individual medical advice on this channel, and certainly check with your own practitioner about anything that you learn on this channel that you want to incorporate for yourself. Yeah, so this is a very controversial topic, guys, and that is whether to use T3. So for anybody who's already on replacement therapy that also incorporates T3, please be prolific with your comments down in the comments section because it's a little scary for people who are thinking about it. First of all, what is T3? So there are two hormones, T4 and T3. Your thyroid gland produces T4, which is the inactive thyroid hormone, and then that gets converted in various areas of the body into T3, which is the active hormone that's free to exert the metabolic effect at all the different end organs. Now, most of the T4 to T3 conversion takes place in the liver. Some of it takes place elsewhere in the gut, but the vast majority is in the GI tract. It can also be converted in nerves, brain, muscles, and elsewhere in the body. So the theory is that people with hypothyroid are not impaired necessarily at conversion. So theoretically, if somebody's T3 is low, you can just give them more T4 and they will convert that into T3. The problem is that a lot of us are finding that that's just not the case. So depending on who you read, somewhere upwards of like 10 to 20% of people who have hypothyroid also have problems converting that T4 into T3. Now, some people are going to say this is absolutely not true. Okay, I personally am living evidence that this was true for me. I know that when I started with my thyroid replacement, it was the T4 monotherapy, which is usual and I think the prudent thing to give early on and see how a patient does. It's also the easiest drug to use. It's the easiest drug to manipulate if you need to. It's the safest one to give because it's really pretty benign and long acting and slow. So back when I started, I got on T4 and I felt a lot better when I had my thyroid hormone replaced with T4, but I didn't really feel all better, and my blood work started coming back, and it looked like, my TSH was back to normal, my T4 looked good, but my T3 was always hovering at subnormal or just at the very lower limit of normal. And all the T4 in the world that the doctor threw at me at that time didn't get me to convert. My TSH would go down lower, my T4 would go up higher, and my T3 would remain right around the lower limit of normal. I didn't really feel well, nor were my labs completely normal until I started to add T3. How do we measure the thyroid hormone? We talk about the TSH a lot. You might hear your doctor say, oh, your TSH is high, which means you're hypothyroid. If your TSH were low, that would mean you're hyper, or the thyroid is too active. Well, why is that? There's a negative feedback mechanism there, but more importantly, the TSH is not a thyroid hormone. The TSH is a pituitary hormone. So it's called the thyroid stimulating hormone. If your thyroid is not producing enough thyroid hormone, that gets detected by the pituitary. The pituitary sort of manages a lot of the other glands in the body, and it tells them what to do. So if there's not enough thyroid hormone, your pituitary will put out thyroid stimulating hormone, or TSH. It starts telling the thyroid, please make more. And the less your thyroid responds to that, the more your pituitary will shout, make more. So the less thyroid hormone that you're making, the more the TSH will go up. So if you have a TSH that's too high, you're probably feeling cold, tired, sluggish. You probably have some dry skin. You might have brittle nails. Mostly people feel that it's hard to lose weight, that they're gaining weight, and that they're tired. Those are the predominant symptoms of hypothyroid. And in that case, when you see the TSH high, it sort of confirms there we have a hypothyroid case. In my humble opinion, unfortunately, too many practitioners look only at the TSH. It's a really good measurement at first to tell you that the patient is hypothyroid, but it's a very crude measurement. And again, it's indirect because it's not looking at the thyroid exactly, it's looking at the pituitary. So once you get that TSH down, there's oftentimes more fine tuning to do that's going to be reflected in other lab results, something like the free T4 and the free T3 and the reverse T3. There's just other things to look at that are more specific to the thyroid and to the body and how it's converting T4 to T3. Another problem with the TSH that fortunately is becoming less of an issue now, but it was an issue and still is for some, which is that some practitioners say like anything under 5 is normal. More recently, people have come to agree that really the TSH shouldn't be just under 5. The TSH, people feel really best when it's under 2, and right around 1, people feel great. Now, of course, you don't want to get too low and become hyperthyroid, but at something like 5, most hypothyroid patients don't really feel that well. And one other problem with looking only at the TSH is that some of these drugs will correct the lab results, but they're not correcting the symptoms in the patient. So just because you get the TSH down to normal, if people are still feeling cold and tired or whatever it is, I think it's time to look at more specific labs. We also have total T4, total T3, free T4, free T3, reverse T3, and I'm going to talk just briefly about the free versus the total. I'm a proponent of looking at free T4 and free T3 because that's the part of the hormone that is free to exert its effect. It is free, meaning it is not protein bound. Total includes a portion that's protein bound and therefore not freed up to be used at the endpoint sites, at the organs. And so if you draw the total and look at that in the lab, you're not really going to know what percentage of that is bound in that patient versus free. To my mind, it really makes more sense to just look at the free T4 and the free T3, and that will give you a very specific picture of what's going on inside that patient. So why is there controversy about T3? Well, besides the notion that T3 should be converted from T4 in the body, and the ignoring that in some patients it isn't, I suspect that there's another issue going on here, and the reason that a lot of endocrinologists or a lot of prescribers in general don't want to deal with T3 is because it is a very rapid acting drug. It is the active form of the hormone, so it is easy to have a problem if you give too much, and it is something that is going to have to be introduced slowly and then tinkered with, and you really have to have the patience and the time and the attention to tinker with it. You're going to give a little bit and then draw some blood a few weeks later, and then you're going to adjust it, and you just really have to expect that there's going to be a period of time during which you're going to have to be fine-tuning. So in my opinion, that doesn't mean you shouldn't have it if you need it. It means that you should find yourself a practitioner who's willing to do that and work with you and tinker with that and watch that blood level carefully and watch your symptoms carefully so that you can end up on a good dose of something that works for you. Let me just say that if you're one of the majority of people who is diagnosed with hypothyroid and you're given T4 monotherapy alone, which really is what everybody should start with, and you get a good result and you feel great and all your labs look good, perfect. And if you're not one of those lucky people and you find you're going to incorporate T3, it's an added burden. It's something that has to be worked with and stuff and watched more carefully. As a person who needed that, I will say it is well worth it, but I'm not trying to sell this for anybody who doesn't need it. So why are some people seemingly unable to convert enough T4 to T3? I don't know the answer to that. I think that it probably has something to do with the fact that a lot of people who have hypothyroid also have other inflammatory issues, particularly gut issues like celiac disease. The gut is where the bulk of the conversion takes place from T4 to T3. So I suspect that if you have some sort of a GI problem, inflammatory issues, that's going to somehow impair your ability to maximally convert what you need in the way of T4 to T3. So how might you decide that you want to explore this issue of whether to supplement with also T3? Well, one thing that might get you thinking about it is if you are taking the T4 monotherapy because you've been diagnosed with hypothyroid and it helps some, but it doesn't help enough. And then typically they'll give you a little more T4, and supplementing with more seemingly doesn't help enough. Either the labs are going back to normal, the TSH has come down, but perhaps some of the free T3 is a little bit low. You still don't feel well. You still feel sluggish, tired, or whatever it might be. Now, some of the feelings that people get, admittedly, those are subjective. In my opinion, it's hard to justify prescribing a drug just based on how somebody feels. I have heard the argument that people just say they feel better on the T3. I personally can understand how a provider would not want to introduce something like T3 that's just based on a feeling. T3 can also be abused, so that's an issue, but that's beyond the scope of this video. I know in my case, and I'm sure in many people's cases, my T3 just never really came up. Okay, so I still wasn't feeling well. My TSH was okay, and that was predominantly because we gave enough T4 that the pituitary stopped screaming. But while my free T4 was right in the normal range, my free T3 was remaining at the subnormal or the very lower limit of normal. And when I got some T3 supplementation that brought that up, and by the way, it didn't bring it up that much, I felt a whole lot better. So some people say that if you're going to supplement with T3, that your free T3 should be like in the upper third of the normal range. Yeah, mine is definitely in the lower third of the normal range. I still feel fine. I feel great. I don't need to supplement any more than that. I know that I'm not hovering down at subnormal, and I'm not having symptoms that you would want to look for of hyperthyroid, like heart palpitations, excessive sweating, and hot. I'm not talking about menopausal hot flashes. inability to sleep, feeling hyper and anxious and things like that might be clues that you have a little too much. I will say that I absolutely resent when providers use that as an excuse for not wanting to prescribe T3. The reason I believe that that is wrong and morally flawed and not even empirically true is because you can become hyperthyroid from getting too much thyroid medication regardless of whether it's T4 or T3. So the things we have to worry about with hyperthyroid are things like heart arrhythmias, bone loss, all very serious problems. But I want to say here something that you should take to your practitioner if you're going to have this discussion. It is not T3 per se that causes bone loss or heart palpitations or arrhythmias or anything else. It is the state of being hyperthyroid that causes those issues. It is the state of being hyperthyroid. It's not the T3 alone. You could get into that state from having too much T4. Okay, it is the state of being hyperthyroid. It's not the drug itself. Of course, it's easier to get into that state with something like T3, and that brings us back around to that fact that you have to have a practitioner who's willing to tinker with it, watch it, adjust it, start slowly and build up. Now, to their credit, the Thyroid Association, which has published standards and guidelines, has now put a statement on its website saying that introducing T3 in the way that I'm going to explain in a moment is reasonable if T4 monotherapy has failed. What they recommend doing is exactly what I've been doing for many years, which is that I take two different things. I don't take Armour Thyroid. I'm not going to get into it. If somebody takes that and you're doing well on it, great. There are other preparations like Armour Thyroid, and then there are compounded preparations that combine the T4 and the T3 all into one pill. I'm not a proponent of that. I think that T3 ideally, because it is so quick and short acting, really should be taken throughout the day. And even the ones that are compounded that are called time release, you'd be surprised how short a time release works. So what the Thyroid Association has said is appropriate to prescribe is two separate prescriptions. So one would be your T4, your l-thyroxine. Usually you take that once a day. It's first thing in the morning. The T4 should be taken on an empty stomach and left in an empty stomach for about an hour. And then you would add the T3 and maybe take it 2 or 3 times a day. I take my T3 3 times a day. So I take one in the morning with the T4, and then I take it twice after that. The benefit of having two different preparations instead of everything all in one pill is that you can manipulate the two different components separately. You really should have the ability to go up a little on one or down a little on the other without having to change the whole preparation. Now, if you're not sure about this, because let's say your provider isn't even looking at your T3, they're just drawing your TSH and your T4, you don't feel well, you might ask to have more extensive thyroid labs drawn so that you can see what's going on with your free T3. If you have a provider that's not interested in engaging in that discussion and you really want to have it, then you're going to have to find yourself another provider. In my experience, that might be a word of mouth thing in your area, a Google search. You might have to shop a little bit. You might have to end up going to somebody who deals with things like women's health and hormones, or you might have to be open to all kinds of things. But make sure that you find a qualified licensed provider who's willing to listen to you and willing to work with this if need be. I can tell you that in my experience, it was well worth the effort of finding somebody. There aren't very many people in my area who at that time anyway would engage even in the discussion of prescribing T3, but I am so happy that I'm taking it. Now, I just can't overstate that I am not recommending this to everybody who has a thyroid problem. Certainly if T4 monotherapy had worked for me, that would have been great. But if you are on T4 monotherapy for hypothyroid and you suspect that perhaps your thyroid could be fine-tuned a little bit better, certainly at a minimum, get some labs drawn and see if your provider will have this conversation. If not, I highly recommend you find somebody who will. Yeah, so I hope this was helpful. If you are hypothyroid and you are on this journey somewhere, please put in the comments section, let people know what's working for you. I think people always find that really helpful to compare notes. Let me know if you've thought about going on T3, if you have done it, had a good experience, a bad experience, any questions you might have, and until next time, be well. Bye-bye.